Hey team, we're going to go through some trach care today on patients. Remember that this should be documented and done every 8 hours on your shift. The ideal times would be with your 6 a.m. assessment, your 2 p.m. reassessment or cares, and then your 10 o'clock at night. So it gets done at least 3 times a day. There's a couple of things that you need. Always have a backup of the trach your patient has in place in the room, and make sure it comes with its obturator. That's this little device. If this is used, if the trach were to ever come out, this would be placed in the patient's airway until we could replace the trach. So make sure you always have a backup trach and an obturator. They're usually kept at the head of the bed. So make sure that gets passed with your patient when they transfer. A couple of other things, you can use inline suction catheters. We'll go over how to use these. With trachs, you can also have an inline suction as well, and we'll go over how to use that too. And then you want your cleaning kits. So these can be found in the ICU supply room, and it just comes with all the supplies you're gonna need to clean that trach. And then you obviously want, if they are available, the disposable, replaceable intercannulas. If they're not available or your patient doesn't have a disposable intercannula, you're gonna wanna clean this, and we'll go through how to clean that properly.
And that size is?
This size is a 8. I don't know if you can see it through the camera. But it's size 8, and you're gonna find the size of your trach on your flange. This one's actually a 6 fenestrated. That's what the FEN stands for. So you wanna make sure you know what size and what type of trach your patient has, and that it matches the box of the trach in your room.
Where can you find the box and the intercannulas?
There are more boxes and intercannulas in the ICU supply room. And respiratory is also a good resource when you're trying to find the size and type of trach you have. So when you are doing trach care, that means you're going to replace the dressing on your trach. You're going to change out the ties on your trach if they are soiled, and then you're going to replace the intercannula. This is a trach mask. This is what it would look like if your patient was on trach mask. Okay, so I will walk through how to change and do your dressing care. Obviously, we're gonna have gloves on and we're gonna wash our hands.
Is this a sterile procedure?
This should be considered a sterile procedure when you're changing out the intercannula and cleaning that. So you're gonna wanna keep this sterile, as clean as possible. Everything else is just a clean procedure. So you're gonna put clean gloves on, not sterile gloves. You're gonna wanna make sure you oxygenate your patient while you're prepping and getting things ready. A couple of things that you need.
What does it mean to oxygenate your patient?
Oh, so when you oxygenate your patient, you want to make sure that you have oxygen on and their sats are above 90, 95, what they've been. You're giving them 100% oxygen for about 1 to 2 minutes to help them maintain that oxygen level. You're going to grab hydrogen peroxide and sterile water, and you're going to do half and half mix. Make sure you discard any that you don't use at the end, because hydrogen peroxide turns to distilled water in light. So I like to get a sterile, clean sample cup, or you can use your tray in your trach care kit as well. And you're just gonna pour half and half, okay? Once you've got your solution set up, you're gonna take, and I like to clean the outside first, and I just clean from the dirtiest to clean, or excuse me, no, I'm telling you backwards, sorry. I like to clean from the cleanest to the dirtiest, but I like to do the outside, and I'll show you what I mean. So you're just gonna unsnap your trach mask, and you can let oxygen kind of blow by, so it doesn't have to be all the way off. I like to then suction the patient. So if you had your inline suction, you're gonna just pop that onto their inner cannula. On this tubing, there is a black mark. That always needs to be pulled back past the green so that you're not occluding any part of that patient's airway if this were to stay in place. Sometimes it will have a syringe on. That is to kind of break up any thick secretions in there. You do not have to flush routinely every time you suction. Sometimes if you're having a hard time or it's really thick coming out, you can inject 1 to 2 C's of fluid. But remember, anything you're putting into this line is going into that patient's lung, and so you want to make sure you're getting all of that back out. So you're going to slowly advance the catheter, let the patient know that it's going to cause them a little bit of coughing, and sometimes it gets stuck on the inner cannula. You just want to twist until it goes down. If you're ever able to not advance this, you want to call respiratory right away. troubleshoot because you don't want to ever have this clog off. If you're going to flush, you're just going to push in 1 to 2 C's of volume. They're going to cough a little bit. You're going to continue to go down. Again, if it's getting stuck, you're going to twist until it goes down. You should almost touch green to green unless you're feeling a lot of resistance. You're going to push and hold as you draw back and keeping it under 10 seconds. And making sure that black line comes back when you suction. Okay, so I always suction first, try to get any junk out. I wouldn't do it more than 2 or 3 times because then you're going to be over suctioning that patient.
What happens when you over suction?
You just cause a lot of respiratory distress, coughing, and sometimes if you're hitting the carina in the lung, you can cause a little bit of bleeding as well. So you just want to be mindful of that. Then you're going to, I like to always take off my dressing. This is going to pull out any blood or secretions or gunk that gets built up around your stoma site here, and you want to visualize. And this is pretty pliable. As long as it's either sutured or secured with your trach ties, it shouldn't come out. So you can kind of lift and look, but you want to visualize this stoma. Then I'm going to take out that inner cannula. You're just going to pop and kind of twist and pull out. If the patient is desatting, you can put the oxygen back on at this point. They still have an open airway. Then you're either going to discard and get your new one, or you're going to clean. If you're cleaning this, you're going to drop it in your solution and let it sit for just a minute. And then this is where you want to be mindful and keep this part as sterile, and don't touch this part, touching only the outside of that inner cannula to keep it clean. Okay, so you're going to drop it in your solution. You're going to take any brushes and you're going to clean and twist, going all the way down, getting any junk, blood, or secretions out of that line, okay? You can also use Q-tips to clean around it. And you want to get kind of aggressive and get this really nice and clean because this is their airway. So if it gets clogged or occluded with any blood or secretions, that patient's not going to be able to breathe. When you're putting it back in, be mindful to only touch this top part. Putting it in at an angle, holding onto that flange, and then just kind of twisting down in. And I promise it goes in a lot easier on a live patient.
And it's preferable to change and get a new one correct, but we're just running low on supplies.
Yes.
So we might have to clean them.
So you're going to twist it down, and then you're going to pinch, and you want to make sure it clips in, and so it doesn't pull back. Because if I didn't push it down all the way and I just set it in, then it's off on this side and can easily pop off. So you want to make sure you clip it down in and it's secured. Okay. The next thing that you want to do is you want to clean around this stoma site. Blood and bacteria love to make infections in patients, so we want to make sure we get that cleaned out. So you're going to take new clean Q-tips in your same solution. You're going to dip your Q-tip or your gauze, and then you are going to scrub and wipe that stoma, going from the dirtiest area to the cleanest. You're going to rub the stoma, get all the junk, blood, secretions out around it, discarding these, and then you'll get a dry one, and you'll want to dry that stoma. The reason why we want to keep this nice and clean, one is for bacteria, so we don't have infections, but also we don't want any skin breakdown. It's really common that patients get skin breakdown right here at the bottom of that trach, and so that's what we want to be mindful of. Okay, once it's clean and dry, you're then going to take your new fenestrative gauze. It's the one with the hole or the slit down the middle, and you're going to place this around your trach. If it's sutured down or really tight, I recommend getting some curved hemostats to kind of help grab and pull. Also, laying your patient flat or having them tip their chin to the ceiling helps open that airway a little bit, and you're able to get around there easier. Okay, you're going to put that dressing in place, making sure you're at least covering on all sides of this flange piece here. And then you're going to put the patient's oxygen back on. Okay, so that trach mask is going to go on top, and then just secure it again here. Okay. All right, and that's how you do your trach care, your stoma care, and changing out the inner cannula. If you wanted to inline suction, let's say we didn't have, or we have an inline suction, but if we wanted to just sterilely suction, this is when we are going to get sterile gloves. You're going to put your sterile gloves on. and they come together in the kit. Okay. Remember from nursing school how to put sterile gloves on? Okay, with my sterile gloves on, you're gonna have this that you can kind of hold and maneuver. Once you start suctioning, one hand will become dirty, so be mindful of that. So what I like to do, so it's not flopping all over the place, is hold this end and then hold here. I'm gonna grab, now this hand is dirty, my suction and connect it, okay? So now this is dirty. I'm gonna tell the patient that we're gonna suction down. You can actually suction right through the trach mask. But if you're worried about being sterile, then you would have that removed. So I'm gonna have you at least remove this for me. And you're just going to twist and go down. And as you get in, the patient's going to start coughing. If you start to feel resistance or meet resistance, you're gonna stop. You're gonna put your thumb on the hole. It's gonna cause this to be negative suction, and you're gonna twist as you come out. Remember, not longer than 10 seconds. Okay, you can do that 1 or 2 more times, so that is how you do inline suction. This would then just be discarded and you would get a new one the next time you suctioned. And then the last thing is, if you wanted to change out your trach ties, these only need to be changed when they're soiled. A few things to keep in mind. If this is not sutured, your trach ties are what is holding this in place. They can either be ties or these nice foam holders here. So this is usually done with 2 people, because once you undo this, again, that's not secured. Something that I like to do in a trick, if you don't have a second hand, is to get your trach tie, your second trach tie, and actually put it around your patient's trach before you take the old one off. So you're just gonna thread the one side through, and you're gonna secure it here. These have a little expander so you can make it the correct size for your patient. And the reason why that's important is we don't want to compress the cervical veins or arteries, because we want to allow for blood flow and drainage in the brain. So you're going to come around the neck, and then you're just going to grab the other side, thread it through so that it's nice and secure before you remove the old one. So you'll put that on, making sure that there's at least 2 finger widths. It doesn't have to be tight, it just needs to be secure. But you want at least 2 finger widths between the patient and the new trach tie. Then you're going to remove the old ones. And that's how you do trach care. Thanks, guys.
I'm trying to think of other questions. What other questions Elise might?
She went over the section. That was what I would care about, yeah.
Thanks, Chantal.
Thanks.